Alrighty, well, welcome to my talk on fibromyalgia. So let's go through some things that you need to know in GP for fibro and a little bit more on the side as well. So, fibro. So let's begin with a couple of facts, a couple of statistics. 5%, 37 and 70%. 5% is the number of patients at your practice right now with fibromyalgia. Meanwhile, 37% is the number of GPs who are confident enough today to diagnose fibro. And then perhaps more worryingly, is that only 70% of rheumatologists define themselves as confident to diagnose fibromyalgia, which, given the high prevalence, seems to be a bit of an issue, doesn't it? So let's see what we can do about turning this room into expert fibro diagnosticians. So I'm going to use the fibro funnel today, I'm calling it. So we're going to take quite a few papers that I've gone through over the month or so, a few case studies and different ways to treat the patient and bring it all into something that you can deal with nice and easy, because I think a lot of people struggle with this condition. So I will try my best. Now, in med school, we may have been taught there are two types of pain. You've got your nociceptive pain, which is as it should be, stimulus response to something noxious in the internal or external environment, and the body tells you about it. You've got neuropathic pain, which is where there's a problem with the central or peripheral nervous system, and there we go. You can see a clear lesion, impingement of the nerve from a prolapsed disc, etc., etc. So there's aberrant signals happening because of a lesion in the central or peripheral nervous system. There is a third type of pain now that we're using. So it's called nociplastic pain. And if you've not heard of it or don't feel as comfortable with it, it's because it was only really described in 2017. So pain from altered nociception, despite no evidence of tissue damage causing activation of peripheral nociceptors or evidence of disease in the somatosensory system. So the International Association for the Society of Pain came up with that in 2017. Now, is fibromyalgia nociplastic pain? Well, actually, the more we look into fibro, the more lesions we find in the central nervous system, which might revise this new term of nociplastic pain into maybe a form of neuropathic pain. So what we often find is the antecedent injury in fibro is that something happens to insult the nervous system. Trauma, and it can be an acute head injury or back injury or something like that, but it can also be actually psychological trauma, where the environment affects something in your nervous system, as well as autoimmune responses, degeneration, and infection. And what happens is a number of things, actually. So we have the hypothalamic insult. So we can see on MRI scans inflammation around the hypothalamus in response to this trigger in patients who go on to develop fibro. We can see things like interleukin 8, substance P, glutamate, all up as a consequence of this. And these are all the noxious things that bring about pain responses ordinarily. So to summarize what we're seeing here is we're seeing hypothalamic changes, which is replicable on imaging. We're seeing neurotransmitter changes. We're seeing changes to the axons and dendrites in the peripheral nervous system. There is plastic growth and movement. There's more dorsal horn neurons. There's more dendritic fields, dendritic arbors as we call them. We even see changes to the free nerve endings in the skin. And the threshold for firing is lower. So across the nervous system, we are seeing replicable findings of changes in the system in response to an insult. Some more things that we see are this thing called NK1 receptor upregulation in the dorsal horns, increased small fiber density in the dermis. And if you've got increased small fibers and free nerve endings in the dermis, then you're going to have a wider gamut for pain. So things are going to feel, like your hyperalgesia or your allodynia. Lower action potential thresholds, as we talked about, and even we even see in these patients that the salivary cortisol levels are up relative to controls. You're saying to me, so what? I'm a GP registrar. What's the big deal here? Well, if we put all of this together, the way that I think about this Having read all of this stuff about it in the last 6 weeks and finding it really interesting, is that I see it as our patients are at the business end of a megaphone, probably multiple megaphones here, and the brain's shrinking away. What's happening here is that the body has lost the ability to triage the importance of the input into the system. Things are coming from all directions. The nervous system is overwhelmed. It's really overwhelmed. In 2016, a long-suffering patient of fibro drew this picture, this fantastic picture, to describe the suffering as a consequence of overstimulation. Apologies. And I think it's a beautiful illustration here. It really sort of sums it up. And the word I come back to in this is salience. It's the ability to work out what is important in the system. And there is an issue with that. So when you can't triage, when your system is overwhelmed, it's going to default to the most evolutionarily important thing, which is pain, because you need to avoid the noxious stimulus, and also to the regions of the brain that have the most amount of processing horsepower, because that which is coming into them has the most amount of bytes and kilobytes and megabytes. When you do a 10-minute audio talk, or when you do a 10-minute video talk, the video is 10 to 30 times larger in size, in file size, than the audio. That's really interesting. So for me, I'm thinking vision and I'm thinking pain. Now, what are some of the key features of fibromyalgia when you're thinking about this? They have widespread pain out of proportion. So pain is their world. Well, yeah, because the issue of salience means that nothing else matters apart from pain. They're incredibly fatigued. Well, if you're constantly putting out fire after fire after fire because you cannot work out what is important, because you've lost the ability for salience and triage, you're going to be exhausted. And so what's going to happen? You're going to get depressed and you're going to get anxious when you're not depressed. And what's the brain going to do to cope from the fire hose of information? It's going to dissociate. It's going to dissociate and move itself away from all of this input that it cannot understand. And that's where cognitive fogging comes in from this information overload. How is this backed up, this theory? Well, if we look at MRIs and functional MRIs, there are two regions. If you look to the anterior cingulate cortex and you look to the visual association cortex, what you see is a massive upregulation of activity relative to other areas which are relatively cool in FM patients, fibromyalgia patients. The anterior cingulate is tying pain to emotions. The visual association cortex is that visual input. So the only two things that are able to be online when you have this issue with the salience regulation are those two things. And those are two huge things that we see. If you wanted to gain control of salience, then you would have to delve into the regulatory portion of the nervous system, which is what we call as a collective term the default mode network, the DMN. And there is a dehiscence, there's a break in these patients. They aren't able to access the DMN. The areas of the brain that are the DMN, that should be regulating them, grounding them, and allowing them with that distress tolerance to figure out what is salient and not, are relatively cool in these patients in recent studies, which is very interesting, which to me validates this approach. So in fibro, an insult happens to the body, an autoimmune response, an infection, a trauma, what have you. There's hypothalamic changes that you can see. There's increased interleukin, there's increased substance P and glutamate, there's decreased GABA, there's increase of NK1 in the dorsal horn. There's changes to the amount of free nerve endings. All of this means that the information that's coming in is a fire hose of content that the patient can't understand or control. So there's a salience failure of crowding modalities. Pain is pushing its way in because it's the most evolutionarily important. Visual association is pushing its way in because it's the biggest in terms of megabytes. And we end up with pain, mood fatigue, and we end up with fog. So the reason I've harped on about that for about 10 minutes is because it's really important to understand your fibro patient and how they're presenting the way that they're presenting. And a core tenet in all of the literature for managing fibro as successfully as possible is helping the patient to understand that it is a pathological process. It's not just all in your head, okay? This is actually, there is changes in every dimension of your nervous system that is completely changing your ability to understand the information that's coming to you. And it is therefore incredibly logical that you are cognitively overwhelmed. It's incredibly logical. It couldn't really be anything else. So now we need to help you to find salience in the chaos. And that's what we're going to go on to help with. So we're looking at these patients, okay? Now, we've already said that 5% of your patients have fibro. Well, 30% of those fibro patients describe at least one of the major symptoms of fibro as causing severe issues with their activities of daily living. So, patient comes to you and you diagnose them with fibro. What's the classic timeline? So, really, this is the classic timeline. They have had symptoms, in 30% of cases severely affecting their activities of daily living for a year before their first presentation to a doctor. It will take them another year and a half, 2.5 years in total for diagnosis. In that time, they have seen at least three doctors, often multiple times, costing every time the healthcare system money. Most patients describe mood, fatigue, and pain as moderate to severe in those 2.5 years. Think about sick days. Think about coming to the doctors. Think about that knock-on butterfly effect for the patient and the patient's families, okay? Now, all these pictures here, including the fall of the Soviet Union, Mandela down there at the bottom, the probe being launched, the release of Mandela we've got. The fourth one is homosexuality being removed as a mental disease from the World Health Organization database. What year is it? It's 1990. Yeah. It's also the year, perhaps less, I don't want to say importantly, but perhaps less famously. It is the year that the American College of Rheumatology finally got together and formally defined a proper evidence-based diagnostic criteria for fibromyalgia. They said WSP, widespread pain, in 11 out of 18 sites for 3 months. It has to be on both sides of the body, above and below the waist, and include the axial skeleton, which is the CTL regions of the vertebral column, the anterior chest. Okay? That was the basics of the definition. You'll note it's purely focused on pain. And so that changed in 2010 because they introduced two things. There's the widespread pain index that they make a lot clearer, and then they've added something called the symptom severity scale. So you need both. 2010 was when that came out. 2011, a self-reported form came out, and 2016 was a better score. Now, the self-reported form picks up a lot more male fibro, but probably has a few too many false positives. The best result that we get is good rapport with the doctor-patient and then doing it together. But bear in mind, you may have to give self-reporters to men because they do struggle to open up about this. So how do I diagnose fibro? Well, this particular way, and I've never looked back. So I Google RCP fibromyalgia form, and it's the first one. The fibromyalgia diagnostic worksheet. It takes you to a one-page PDF. Print off a ton of these and stick them in a drawer. I'm not paid by the RCP. It just has everything you need to know. It's really simple, okay? So we start with the SSS, the Symptom Severity Scale. So for the last 3 months or more, have you had fatigue, trouble thinking or remembering, waking up tired, unfreshed? You give them a score out of 3. And then in the past 6 months, have you had pain, cramps in the lower abdomen, depression, or a headache? Score 1, 2, 3. So the total score there is 12, okay? So that's part 1. Then you go to part 2. You give the patient the form and you have them shade on it where they have experienced pain for the past 3 months that's persistent or recurrent. Okay? And then you look, calculating the WPI score here. Okay? So you then tick off those things in the different regions. And it even tells you here. Diagnosis, you have to have the widespread pain for 3 months with a widespread pain index of 7 or more, so 7 or more of those being ticked, and an SSS of 5 out of 12 at the top, or widespread pain index of 4 to 6 and an SSS score of 9. For the second part of the criteria, you have to have pain in 4 out of the 5 body regions. Upper limb right, upper limb left, lower limb right, lower limb left, axillary region, right? So that's how you diagnose fibro. It's all on one sheet. So 37% of GPs are confident diagnosing fibro. 70% of rheumatologists are confident diagnosing fibro. That sheet, outsource it. Outsource it. You're busy in clinic. You've got loads of patients to see. You've got loads of conditions to see. Look at that sheet. Print it off. Save it to favourites, whatever. So, the mood component associated with fibro. 50% of patients will have moderate, mixed anxiety and depressive disorder as a consequence of this fibro. When we talk about that issue of salience, you can tell why. Interestingly enough, 40% do not tell, and the vast majority of them are men. So a lot of people are suffering in silence here. To investigate, I just do my usual tired all the time bloods, so I do my routines including lipids, RP is renal profile, and then A, B, C, D, so we do anemia and IgA, TTG, B is B9, B12, maybe Bence-Jones protein if they're a certain age, calcium, mag, CK-CCP if I'm concerned about that, vitamin D in a dipstick. So that's my tired all the time screen. Now, how are we going to manage these patients? What are we going to do? Well, let's think conservative, medical, and then specialty. Because, sorry, surgeons. A, B, C, Ds. A, aerobic exercise. Perhaps better than aerobic exercise is Tai Chi. That's getting evolving evidence, which is pretty cool, I think. And Tai Chi might be a bit more accessible for patients. They can just get up videos on YouTube, that kind of thing. Aerobic exercise might be a bit harder. It might need gym gear, might need a bike. But aerobic exercise is anything that gets your heart rate up. So walking, so you can't complete a full sentence, is fine. But also, you can tell them to go out with a rucksack and put some books in the rucksack, because there's evolving evidence, actually, that you can really increase the efficacy of walking for aerobic fitness if you're having weighted activities. So that's quite interesting. Acupuncture. Acupuncture has some of the best evidence, including drugs. It's really interesting. Acupuncture is emerging as an excellent intervention, and it's often a linchpin, if you pardon the pun, of what they do in specialty clinics. B, behavioural, so cognitive behavioural therapy, but also things like mindfulness based MBSR, mindfulness-based stress reduction, and these kind of things. Now, these are an acceptance commitment therapy and the like. These are very, very important, okay, because they're grounding the patient. They're treating them not only to cope, they are treating them to bring to dysregulation compassion. And actually, it sounds wishy-washy, but if you are not able to understand what is serious and what is not serious in terms of input, you have to assume everything's serious. You're overwhelmed, you're terrified. We're back to salience as an issue. You can help to remove the fog and the dissociation by helping them to feel less aroused and afraid in those stressful situations. And that emotional regulation is so important, and it's hard, it takes time, it takes a daily practice. They can get there. And the centralization theory, so this is about saying that patient information and patient empowerment is absolutely key for fibromyalgia. We have got to empower the patients, and doing that with this kind of information about it being an issue of salience and the inputs, and that there are changes in your brain. If I were to scan your head now, it's real, validating it, and here is what we can do to help. Managing depression and anxiety as well, because 50% have moderate to severe depression and anxiety. So it's a coin toss that that person in front of you has a diagnosable mixed anxiety depressive disorder with fibro. So that's really important. For exhaustion, the usual things like sleep hygiene, which you can stress, and there's a ton of information leaflets the NHS have to support with that, but also screening for other things that might be affecting their sleep. So they're knackered as it is, and they've got restless leg syndrome, because patients can have as many conditions as they please, right? So I've gone to Hungary here for this beautiful ceiling of the National Opera House to talk about ceilings of care. And ceilings for realistic appraisal. And it's the same number for the efficacy of sumatriptans and for prophylaxis of therapy, because people take propranolol for migraine, they expect it to cure them, right? Or sumatriptan, they expect it to completely abort everything. But it only has 50% efficacy. And the best combined interventions for treating fibromyalgia will reduce your symptoms by up to 50%. And really, the patients need to know that relatively soon, because they need to know the goal that we are shooting for is not cure. Sadly, it is management of the chronic condition, which frankly is what we're here for. That's the job of a general practitioner. That's the job of a medic in the 21st century, right? So, pain, sleep, mood. If you think of those about the three pillars that we're focusing on, pain, the first line drug, amitriptyline. Sleep, the first line drug, pregabalin. Mood, the first line drug, duloxetine. For your amitriptyline patients, we often start with 5 milligrams and we up titrate monthly, right? So amitriptyline at night, right? The evidence shows that anything above 30 milligrams as a total daily dose of amitriptyline for these patients has limited efficacy and only introduced the side effects, your mad hunger side effects, mydriasis, agitation, dry stuff, hypothermia, orthostasis, retention, seizures, arrhythmia, or flushing of the skin, okay? So 5 monthly increments to 30, anything above 30, you're not winning with amitriptyline. So if you're starting a patient on amitriptyline by month 4, you should have a realistic idea of if this going to go anywhere, if I'm honest. Pregab, so pregab, 75, you can start at OD or BD usually for these patients. And again, it's monthly titering. 300 milligrams is usually the sweet spot for these patients. You can go up to 300 BD, but again, you start to introduce the side effects, which are sedation, we don't want, weight gain, they feel worse about themselves, dizziness, they're just restricting themselves more. They're overstimulated even more. So pregabalin, not to mention all the dependence that we get with pregabalin, is a worrying one, okay? And it does have evidence, but it's the weakest of the three. What about duloxetine? So duloxetine for mood, 30 milligrams, up to 60 milligrams. Now you'll notice that none of these are licensed for fibro, and the ceilings are much lower than what it will say in the BNF that you can go to, because you can go to 120 for duloxetine, right? You can even go higher in secondary care. But 60 is the ceiling where if it ain't working, it ain't working. So pretty quickly after a couple of months of amitriptyline duloxetine, you can have some idea of what's going to work here. And then duloxetine, because it's an SNRI, most of its effects, the side effects, are the same as your SSRIs, right? So, the number of patients who are concordant with therapy for fibromyalgia at the end of the first year are 30%, and 40% stop due to side effects. I reckon a lot of that 40% stopping due to side effects are because we have heart sync about them and we put the doses too high before saying this isn't working. And we're not focusing enough on the conservative measures. Okay, and with evidence base, and the patients are betting a lot on the drugs. That said, we can go dual therapy, although we don't do it in primary care, but it's done readily in secondary care. And the classic one is that they'll do duloxetine in the morning and amitriptyline in the evening, and that's the combo. When we're thinking about amitriptyline, we start to see serotonin activity in a TCA amitriptyline at 75 milligrams. So I've told you that that's way above the ceiling of where we want amitriptyline to be, way above the ceiling. So you shouldn't be getting to serotonin activity, which means this is why secondary care do dual therapy so liberally, because they're never getting amitriptyline to the dose where there's serotonergic activity. And if you're not, the risk of duloxetine amitriptyline goes way down because the risk of serotonin syndrome, which is low enough when you're augmenting in major depression, which most of the Western world accepts and the UK doesn't, is even lower. Okay? So, you send the patient to a fatigue clinic and they have 3 pillars that they really go to. Emerging at the moment is low-dose naltrexone. And low-dose naltrexone, they have found, activates the glial cells that are regulating the neuronal firing and actually calms down this overburdened system that's being crowded out and allows better access to the default mode network. There's also transcranial direct current stimulation of M1. Now, M1 is your motor cortex, your primary motor cortex. But the primary motor cortex, if you remember, medially is right by the cingulum. It's right by the anterior cingulate cortex, and it's close-ish to the limbic system. And it actually has a role with emotional regulation of pain, just like S1, but they found best results of directly stimulating transcranially. So there's no direct, well, there's no invasive, it's transcranial. And then cannabinoids as well has some evidence, but it was not what we'd had hoped it would be. So a kind of tenet here to take away is that if a patient is concordant on dual therapy and they have failed to improve, they're not going to improve in a fatigue clinic. They're not going to improve in it. So we're not winning, which is really interesting because in North America, they will expect the primary care practitioner to have failed the duloxetine amitriptyline before the fatigue clinic sees them. So it's probably pretty miserable working in a fatigue clinic outside of the UK. In the UK, they'll immediately put them on dual therapy, give them some acupuncture, and give them some better funded supervised exercise programs. And something can come out of that. But we don't do that. And there's this thing called FIQR. This is quite good, actually. So FIQR is, I don't think it's on MD Calc, but it's open access. You can readily find it. And it's a validated way for assessing how the treatment is going. And you can have that nice little number, FIQR equals, and you can code it in EMIS, so you can see in each interaction how well the patient's doing. At 8 years, it showed no sustained change versus the primary care intervention by sending these patients to fatigue clinic. So there is no long-term benefit from a fatigue clinic for fibromyalgia. Now, these 2 quotes from the literature in the last couple of years are pretty devastating for where we are with fibro. But I'm not going to leave it at that. I actually, my first draft left it at that, but what is on the horizon? What is on the horizon? Well, there's 4 things at the moment on the horizon that look relatively promising. The first is vagal nerve stimulants to help with co-regulation of the system. The second one are new targets of transcranial direct current stimulation that aren't just M1. The third one is pretty cool, actually. It's using MRIs and fMRIs for targeted therapies. So there's a really cool study published last year in the Journal of Rheumatology that showed that you can use MRI anatomy to determine which of the 3 drugs, pregabalin, amitriptyline, duloxetine, will work for the patient better than the predominant symptom, which is really cool because it shows that actually you could scan the head in fibromyalgia and then you could say to yourself, ooh, well, actually, that's not going to benefit the patient. And then you can think about things like experiential therapies that we talked about, MBSR, ACT, coherence therapy, there's a lot of them. What we want to do here is to go from doctor imparting to patient to this empowerment. We give a bit of information because the patient has to do these behavioral actions and this emotional regulation every single day at home, multiple times a day. We can't be there. A therapist can be there 1 hour a week, but it's about, are you doing the homework? Are you doing the homework? And I'll end with this quote, okay? So I'll end with Maya, lovely Maya. We may encounter many defeats, but we must not be defeated. So that's my talk about fibro. Thank you very much.